Hello, and thank you all for joining me today for a event hosted by the American Enterprise Institute, where I will engage leaders from the private sector who are working in healthcare delivery to deliver more efficient, cost-effective care. Today, we're going to focus on how the Inflation Reduction Act, which represents one of the largest government interventions into drug pricing since the Medicare drug benefit was implemented, will affect those companies that are working to develop drugs and get those drugs used more efficiently. I'm joined here by three panelists, and I'm going to ask each of you to please start off by introducing yourself, the company you work for, and how you're connected to this topic of Medicare drugs, prices, and both private and public sector initiatives to restrain prices and costs. I'm going to ask Robin to please start us off.
Thanks, Kirsten. So I work for Viver Health, and basically we work with biotech and biopharma clients. We also work with specialty pharmacy and select healthcare companies in the PC, private equity, and VC world. We really have a goal to improve the quality of care and really enhance the treatment paradigm for patients. So what are we really doing at the heart of our work? We're designing clinical and integrative interventions that tie to outcomes and the health benefits of changing this treatment paradigm. So we're really focused on total patient care and reshaping what value-based care looks like. My background is in market access and reimbursement, which includes pricing and contracting and negotiation for access and reimbursement. I've been in organizations such as Schering-Plough Corporation with the JV with Merck, Boehringer Ingelheim, Pfizer, and Biogen. But I've also spent a fair amount of my time and my career in retail and specialty pharmacy providers at Walgreens and Diplomat. So what we were really essentially doing was negotiating for in-network agreements and really providing the clinical high-touch patient care wrapped around these patients' unlimited distribution and infusion drugs. So obviously we're in the thick of talking and speaking with our clients and trying to understand the potential real or perceived impacts with the IRA. Happy to be here today, and thank you.
Thank you. Kent, could I ask you to describe your current role and some of your experience as well in your connection to this topic?
Yeah, absolutely. Thanks, Kirsten, for having me. I'm Kent Rogers. I lead the commercial effort here at EQRX. We are a emerging biotech manufacturer that's actually a disruptive player in the oncology and immunology space. I joined EQRX a few years ago after about 30 years or so in our industry. I've been on several sides of the desk, having worked at Schering-Plough with Robin, Merck, as well as a small biotech, Accorda Therapeutics. Spent some time on the consulting side, working with manufacturers and their supply chain strategies. And then before joining EQRX, I spent about 6 years leading the formulary strategy as well as procurement function at OptumRx, which is the PBM for United Health Group. So having been on all sides of the desk, I've got an interesting view from the perspective of not only the government and their interventions within the healthcare system, but how Medicare and the Medicare Modernization Act and ACA and the implementations of these legislations have occurred over time. Our particular space for our company is actually, as I mentioned, in oncology and immunology. So there's at least a third or more of the patients that we would be addressing with our medications that are in Medicare. And the implications of what the IRA have are of course, potentially are broad reaching for all companies within the industry. But this is an interesting time to be talking about it, as there's still a lot of unclear portions of this, and looking forward to the conversation.
Thank you. And now, Ryan, could I ask you to please introduce yourself and your role?
Thank you, Kirsten. I'm Ryan Collins. I'm the co-founder and CEO of Edenbridge Pharmaceuticals. Edenbridge is a spec pharma company that's been around for about 15 years now, specifically in the small molecule space. So in my role here as co-founder and CEO, I'm partially responsible for selection of new products and commercializing those products. So this act and its sort of manifestations will change our portfolio for years to come. So it will change the things that we develop, but probably more likely it will change the pool of things that we can develop from, and maybe decrease small molecule development across the board. So I'm very interested to talk about this today. Thank you so much for having me.
Thank you very much. So just as a bit of background and level setting, I'm going to take us through a few slides. We've already introduced our panelists, and really so today there's lots of organizations that work in the private sector to constrain costs, particularly in the Medicare benefit. And as you heard from the panelists we have joining us today, we're going to talk today in particular about novel models for R&D that look to develop drugs sort of more efficiently, more quickly, the use of evidence-based patient care management and pharmacy management, including specialty pharmacy. So we think about what is driving Medicare cost growth. It is some of those higher cost medicines. So that specialty pharmacy care management is also a really relevant part of this discussion. The Inflation Reduction Act will permit the federal government to establish the price of the biggest drugs, sort of the biggest selling drugs in Medicare, with the goal of reducing costs. This is a significant departure from how Medicare Part D benefit was designed. It was originally designed with the idea that the PBMs and the health plans would negotiate with the biopharma manufacturers, and that would result in a constraint of the net prices, not the list prices. In fact, discounts have been going up over time. So have prices, and so have generics. So in some ways, the built-in private sector cost constraints have been working, and in other parts of the benefit, there has been cost growth that has exceeded expectations. Again, today we're going to focus on what this change in law means for the private sector entities that are working to constrain cost and deliver value. A few things to consider about cost growth in the Medicare benefit. The average cost of prescription drug has declined on average from $57 in 2009 to $50 in 2018. That is average across brands and generics. So what that reduction really reflects is the proliferation of generics in many of the highest use categories for chronic disease conditions such as cardiovascular disease, depression. And 90% of all prescriptions are generic. The average Part D premium has hardly increased from 2007. Of course, there is variation across different plan types, and people in certain plans may have experienced an increase if they haven't switched to the lowest cost plan or that isn't available to them. But patient out-of-pocket costs have been going up. Deductibles have increased to $250 on average. That's $150 greater than in 2007, and that's more in the standalone drug plans. And there's also been a large increase in specialty tier coinsurance, particularly in Medicare Advantage, which is the integrated medical and drug benefit plan. That also happens to coincide with a large increase in the number of specialty drugs. So it's not just the cost management, but it's also the types of medicines that are being developed and delivered. Government expenditures have doubled since 2008, and that's been primarily driven by enrollment increases, but also the sort of legacy of the benefit design and changes in the benefit design over time, where the government has taken on a growing burden for people who are higher cost beneficiaries who reach a catastrophic level of coverage that is heavily subsidized by heavily subsidized by the federal government, which will be reduced as a result of the Inflation Reduction Act. So, in today's market, both in Medicare and in commercial insurance, drug prices are largely negotiated with net discounts. Of course, there are certain therapeutic classes where there aren't competition, and you aren't going to see that same level of discounting. The Inflation Reduction Act focuses on Medicare drugs and limits the prices and cost to patients. That is the really sole focus in the healthcare area. And I think part of the discussion we'll have today, particularly with Robin, who looks at total cost of care management, is that focus on drugs one that's going to save money and be efficient in the long run. The IRA is being implemented quite quickly with some opportunity for input, but it still remains to be seen how the private sector will be engaged on providing feedback into the operations of the law. And importantly, this law will have an impact, as Ryan mentioned, on what drugs are developed and how drugs are made available for the elderly and disabled who receive their drugs largely through Medicare. I'm just kind of considering the magnitude of this change. Medicare is currently 28% of the US revenues for drugs. Not all of the drugs will be negotiated, but again, I think it's part of what we'll have in our discussion is even with 10, then 15, then more drugs being negotiated, whether you are a drug that has been negotiated or if you're launching a drug into a class where there has been negotiation, that affects the dynamics. Similar to when the statin class became largely generic, that affects any later entrants who are kind of entering into a market where the benchmark is low. And that will definitely affect companies that are developing the next generation of drugs that may have come in and competed and driven down net prices or potentially improved health. So 4 key provisions of the Drug Act. We're going to focus on the price setting and the risk management. Drug companies also are going to be required to pay back increases in the drug price if it goes faster than consumer inflation, and that is the list price, not the discounted price. And then Medicare beneficiaries' out-of-pocket costs will also be limited as a result of this law. So sort of speaking on industry impact and what we have left, or industry input and what we have left to know. CMS did recently issue a memo describing how public comment will be collected and some of the initial timelines for implementation of the first round of price setting. There will be guidance issued in the spring, and it'll be open for public comment. As you read the memo now, a lot of that guidance, or a lot of what is likely to be coming in that guidance, appears to be focused on data elements and how data is captured, but not so much on how evidence and value are assessed. I think that should come to no surprise to those who are familiar with the law, because there is a ceiling price, there is a benchmark. CMS has to get below that. So if the value of the drug would be assessed above that, there's really not an opportunity to have a real value assessment when there is a ceiling, because by definition, value, if it's above that, it has to be set aside. The first 10 negotiation eligible drugs will be selected from Part D. So that's the pills part of Medicare benefit, the kind of drugs usually pick up in a pharmacy. And then manufacturers will enter into a price negotiation agreement. In reality, while the manufacturers do have the right to counter offer, they don't have the right to walk away. So I'd say Robin, who was in the health plan side for a number of years, could maybe give us a little bit of comment on how that differs from a negotiation that they might have with a health plan. And then the prices will be published in September of 2024, and then the maximum prices will go into effect in 2026. So really the market and those companies will have a pretty good sense of how much their prices are likely to be brought down in the coming months, even before the price negotiation is published. Again, we know what the benchmarks are likely to be. The prices will remain set and will go down until a new year is triggered. Basically, over time, the prices will come down. Again, thinking about value, typically the prices don't come down until roughly 14 years after a drug has been on the market. That's when typically the data protection expires and generic entrants come into the market at a very low price and draw away close to 100% of the business. And in this case, for small molecules, that price setting will happen after 9 years. So that cuts about 5 years off of the end of a potential revenue stream for a small molecule. For a large molecule, it will come in at 13 years. So it's a more punitive impact on a small molecule relative to a large molecule. So some of the things I'm going to ask our panelists to consider today, value, while it was a big part of the Affordable Care Act, it's not explicitly considered in this law and price setting. So how do private sector entities continue to encourage value and value assessment on what is bringing the most cost-effective and efficient care and benefiting patients in the healthcare system? This will mean there'll be less investment in certain types of medicines, particularly the most popular, biggest selling medicines and their competitors. Is that the right way to allocate our costs and investments? How will later class entrants be affected when they come into a low benchmark? What's the potential effect on rebates and discounts on the net price that health insurers have to pay? And that also affects typically what copay and tier patients are seeing in their formulary. And then finally, what is going to be the role for health outcomes measurement and rewards for value in this new post-IRA world? So I'm going to stop sharing. And I'm going to start with a question for all of our panelists, and maybe I'll ask them to answer in the reverse order, starting with Ryan. What do you think are the most effective approaches to control the cost growth for medicines? And that could be either private sector or public sector approaches. And do you think that focusing on drug cost growth is the right aim for patients and for the health system?
I'll answer the last one first. I think it's one piece, and it would be disingenuous of me to say that drug prices aren't a factor, but we all know that hospital pricing and various parts of the healthcare sector play into this. What do I think the best mechanism is? Of course, I think it's the market. I think it's the introduction of generics and competing therapies against the existing therapies. And I know it's a question for a later time, but I would like to see that market work in this case as well. You're looking at a nascent biosimilar industry. I'd like to see it work there. I'd like to see it work in the same way that you mentioned, Kirsten, which is 90% of the scripts, and I think that's 20% of the cost, or maybe 16, somewhere in that general area. So, of course, I believe in the power of the market here to bring the most value to the end-use consumer.
Thank you, Kent.
Yeah, a couple of thoughts to add to what Ryan had said is that within the industry, today, employers in the commercial space, about greater than 50% of the spend is in about 1% to 2% of the volume of prescriptions. And as we've seen a growth in the specialty categories and the genericization of more primary care categories, that's really been the focus where pricing has caught the attention of not only government, but of course the commercial market as well. And the government's focus on price is one lever that they, at least in the IRA's implementation, they feel that they can control. But really what is also an endemic issue, and Ryan mentioned this in his comments, we are a percent of supply chain business. So whomever touches the drug, whether it's a pharmacy benefit manager, anyone within the supply chain, the revenue and or profitability within the supply chain is predicated on the price of the medication. So the implications for something like this is broad reaching because the infrastructure is based that way, right, wrong, or indifferent. It's evolved, and frankly, with the higher cost of medications, that's actually brought quite a bit more revenue within the supply chain. And of course, the attention has been brought into, well, where does that money go? And does it really benefit patients? And who's really footing the bill here? So I see the IRA in many ways, and we'll get into this discussion, of course, as symptomatic of a kind of evolution of not just the drug pricing, but how the system and the percent of supply chain construct has evolved with that as well.
Robin?
Yeah, so to add on to what Ken and Ryan have already said about competitive markets, looking at just controlling drug costs without a clear pathway that includes a value and a value framework, you really need to look at the innovation of the drug and what value that drug brings in improved outcomes and care. But you also have to look at the provider service and service delivery model and what those treatment outcomes are also included into that. So it's a combination of both of those factors when you're looking on the impact of total cost of care and, more importantly, the impact on the patient. So there were factors to consider around value within this framework, but there really wasn't any clarity on how these factors are going to be considered and how these negotiations are going to be handled. So when you lack that level of clarity around components of value in a true value framework, you're really just cutting down to basic revenue and cost of the drug. And I don't think that that's good for the private or the public sector markets.
Well, thank you, Robin. And this next question is going to go to you because it really is focused on value. So the Affordable Care Act, or Obamacare, was, up until the Inflation Reduction Act, one of the biggest changes in healthcare policy in decades. It included a strong emphasis on value. center for testing out new value models, new incentives to drive values by paying for better health outcomes. This law is really silent on value, a relatively limited role in the drug price setting. So how do you think it will have an effect? And of course, as a result of both private sector push and the Affordable Care Act, a lot of private entities built up to help deliver more value and measure that and change payment models. So how do you think this law will have an effect on private sector efforts to improve care delivery enabled with technology or evidence?
So a couple of thoughts on that. You know, there's really been great strides in value-based healthcare, where the reimbursement and payment models are really tied to the quality of the care provided, right? In addition to that, you've seen with the best price rule, great advancements in how value-based contracts and value-based agreements are really being designed, both around drug and the care delivery aspects of it. Without setting up the future for continued progress in these areas, because you've in essence negated some of the focus on outcomes, quality, and the value around the total cost of care, there could be an impetus to set things backwards if things stay as they are designed today, and that's a big if, right? But if you look at bucketing this in sort of factors around drug and then bucketing this in around care and provider service delivery, let's take a look at the drug aspects. If you have 9 years for market exclusivity for a small molecule and 13 for a large in biologics, are we now pushing the innovation model to be more towards large molecule and biologics versus small? When you take a look at orphan designation is excluded from this, are R&D investments in biz dev investments going to be more focused in these areas versus others? If you take a look at oncology drug innovation and oncology drug R&D research, many of these products are launched with a narrow indication and one indication, and follow on research and follow on investments in understanding additional indications usually happen. Is this now a perverse incentive not to do that? And when you also take a look at pediatrics, plasma-derived therapies aren't part of this. How does this impact the entire biz dev and RD investments that the private sector is doing? And lastly, I'll say we've had huge progression of value-based agreements, even inclusive of gene therapies, where there's product guarantees and product warranties. Now, these gene therapies are excluded, but the value-based agreements that have incurred around oncology care models, now is this going to be negated or potentially even changed? And then when you just get down to if maximum fair price and cost setting is really going to be what is the new reality, with really a lack of true value in that equation, you'd have to ask if a manufacturer is going to have their asset commoditized immediately upon launch, are they potentially going to raise and launch with higher list prices to improve their gross to net? So let's flip it over to the care and the provider service delivery side, where value-based healthcare, accountable care models, tremendous progress and tremendous partnerships and be able to improve the impact of effective care and the outcomes for the patients. If this maximum fair price is actually disrupting the ASP model for buy and bill for physicians and providers, you have to really consider some downstream implications around this. These providers rely on that spread to be able to care for those patients on particular drugs in their offices. So now if a provider can't financially take possession of that drug and treat in that office, are they then switching that patient to another drug that they can afford? Is that the optimal drug for the optimal cost and value in outcomes? The other aspects are, if that provider can't care for that patient in that care setting, are they going to remove them and transfer them to another site of care? If that site of care is in a hospital setting, that has huge implications on increased costs you also have to factor, if that patient is being transferred, what's happening to the care coordination and the outcomes and the metrics around how that patient is being treated today and where they're going in the future. And, you know, if providers are now moving patients around in a site of care situation, it's impacting care models. It's also having an impact on provider network and hospital networks that are reconfigured. So there's a lot to be determined, but definitely the way it is designed today, it would appear that the progress we've made around drug and the progress we've made around care delivery systems in value-based healthcare could have unintended consequences.
Thank you, Robin. I'm going to remember your answer when I hear again, it's just 10 drugs. Because I think we don't quite appreciate, and we only have to look at models like how the 340B program has affected provider economics and hospital consolidation. The price of drugs and intervention to that price of drugs can have profound effects across the healthcare system. So thank you for that answer. Ryan, I'm going to put the next question to you. How do you foresee lower cost drug development having the most potential to reduce healthcare costs, and maybe its particular therapeutic areas or classes that are prone to shortage? And what are some of the challenges that you foresee in developing sort of more efficient, in enabling more efficient drug development and delivery?
Sure. If we're talking about, the biggest impacts from generics or biosimilars, I think they're in all disease states, from, the most widespread disease to the tiniest rare condition. Generics, especially in the small molecule space, they're there. And if they're not there, they're coming. And, they do the things we just talked about, which is 90% of the scripts for 20% of the cost. And the more generics that are launched, obviously, the better that pricing does. I think it's something like the biggest reduction comes after the fourth generic or something like that. Don't quote me on that, but that's fairly close, I think. So I think, again, no matter the disease state, the introduction of generics will bring that price down. Where I see this act specifically, maybe having those unintended consequences that Robin talked about, I mentioned it in my introduction, it's in shrinking the pool, or in, putting your thumb on the scale of what will be developed, going from that 14.5 years that you mentioned, Kirsten, to 9 on those small molecule drugs. Maybe that chokes the pipeline off for what's being developed there. Everybody puts their money into biopharmaceuticals in the future, and then the development costs from a generic standpoint are just drastically different there, right? In the small molecule space, we can bring a generic to market for low 7 figures. In the biosimilar space, you're talking about 9 figures, and that's just an entirely different ballgame from an R&D spend perspective. So, as Robin mentioned very eloquently, it's the downstream effects that we're not expecting, and it's all of that reverberation through the different parts of the supply chain that will hinder that generic development, which is the true cost saving driver.
And Ryan, let's ask you a follow-on to that. With the federal government pushing down the price of certain small molecules to 25% of what it is today, are you going to get that fourth generic? How do you think that'll affect the generic or biosimilars to enter the market?
So I'll answer that unsatisfyingly as it depends. There, it probably does depend on the disease state. So as a generic developer, I would tell you, to do a bioequivalence test, it's probably not going to impact me there because my out-of-pocket is not that great. But if I'm doing an endpoint study, if I'm playing in Kent space, if I'm bringing an oncology drug to market and I'm doing, true clinicals, then maybe, then maybe I won't commit that capital to that development because that's a significantly different development cost. But it depends in that case. And then the biosimilars we mentioned is an entirely different deal. 9 figures for development and years in the process. Probably not. You probably don't get that fourth generic. Look at Humira right now. I mean, that's the greatest experiment we're ever going to see in the US biosimilar market with, I believe, 8 approvals currently. You're going to see 2023 play out in a real world economics experiment. And that's the real test.
Excellent. So Ken, I'll put this next question to you. So how will the price controls in the Inflation Reduction Act affect your company's ability to compete against established drugs, particularly those established drugs that may be price controlled? Is there still going to be a reason to focus in the same therapeutic classes, or do you think there'll be a shift either to different therapeutic classes that are maybe more those rare diseases or outside of the elderly and disabled population?
Well, actually, first, both Robin and Ryan had unpacked so much stuff. There's another couple hours to talk through a lot of what they said, and all very, very, very good points in terms of the effects that it has. So I'll answer your question in the context of one of the disease states that we would be competing in, and the specific category which would most likely be exposed from a cost perspective early on in the IRA. When you consider the site of care shift that Robin was talking about, anytime you enter into a market, you're concerned as a manufacturer, not about just what you can yield in terms of uptake, if it's in a competitive category for sure, but there's oftentimes a goal for manufacturers to protect the ASP, protect the price of their product so that the administering provider and/or organization that is dealing with the patient on a day-to-day basis has their profitability protected. When you consider that, and I'm putting a little bit of my payer hat back on here, when you consider that as one of the things that manufacturers have to be concerned with, is that really something they should be concerned with? And what I mean by that is that, unfortunately, both Cigna, United Healthcare, Aetna, Blue Cross Blue Shield of Tennessee, Rhode Island have not been successful in efforts to try to take patients out of a hospital setting into a pharmacy care setting that is either closer to their home. We've got pharmacy deserts all over the country that patients are driving 3 or 4 hours into an infusion center, being treated for a few hours only to drive 3 or 4 hours home. They may live in a project within an urban area and unable to get to a university setting, either for a clinical study and/or for treatment, but aren't able to be treated in their home. These are the kinds of site of care needs that are in the marketplace that, frankly, insurers have been asking for, but they're going up against a hospital system where 340B as well as 1,000% markups occur. And in one of the categories that we're competing in the PDO or PD1 space, the average markup in a hospital setting is 430%. That means the employer is paying $1 million. That's a commercial side of it. But Medicare is impacted by that as well. And from the perspective of you're a manufacturer entering into this space, in the PD1 specifically, there's 8 products in the market, and they're all about $200,000 in annual therapy. So the advocate of an IRA would say, why would you pay, or why would you have a price tag of $200,000 if you're the 3rd or 4th to market, much less the 7th or the 8th to market? And while there may be incremental benefits in terms of dosing and/or some safety or mild efficacy advantages, most of the time payers see that as in a broad range of therapeutic equivalence. You have to be lights out different in terms of safety or efficacy for it to make a difference. And if it's dosing once a day versus twice a day, that's not considered clinically significant unless it has a real impact on the safety of their efficacy. So when we're actually reaching for drugs that we're trying to manufacture and promote at EQRX, we're actually going after those categories where we see as a target area. If there's 2, 3, 4, 5 competitors, no one has had the innovation of price. And to Ryan's point, when you've got 9 figures and 7 to 8 years on average, which limits your amount to commercialize the product, you could say, well, that's the reason the prices are high. I think we would posit, why does it cost $2 or $3 billion to get the drug to market? Is there a more efficient way to do that? Do we all have to stand in line and get our IRB approved in an academic center and take years or 2 to enroll the study, much less get them completed? Is there a more efficient way to do that with multiple centers, maybe less experienced in getting drugs through the development phase, but it's on us to reduce the investment of getting that drug to market so that we can actually turn around, as EQRX is intending to do, and have a social contract, if you will, to be able to price it responsibly. The tough part is that we're actually getting a little bit of criticism that maybe we're stifling innovation in what we're trying to do here. But I think what our model is very much speaking to the idea that in certain categories where you've got 2, 3, 4, 5 competitors, and they're all priced the same, trying to find yet a smaller piece of the same pie, price continues to go up. It's the only lever that you can actually employ. So I think in that respect, even though there's a lot of downstream implications to this, some good and some bad, it brings some pretty provocative questions. First, do we need 4, 5, 6 medications in a category, especially if they're going to be priced the same, and we still have, longevity in the LOE timeframe? And second, from a site of care perspective, should physicians be buying and billing and profiting off of medications, or should there be a site of care strategy that eliminates that altogether? What Robin mentioned, which is true, if you don't fix the idea that the administering provider's buy and bill construct atrophies as a result of this kinds of thing, and 10 becomes 100 by 2030, by the way, then you're going to be subject to dramatically increased costs if you're not willing to take on the hospital markup situation, especially in the commercial space. And I have not seen an administration even bring that up yet, because let's be honest, the boards of hospitals, they're dominant employers in their areas, and they help state senators and congressmen and congresswomen get elected as well as federal. And that is one heck of a lobby to go after. But this kind of legislation, I think, has implications, if for no other reason than if site of care starts to really shift from these large cost medications into a more costly site of care without any freedom to be able to adjust to that, then it could have some inherent cost drivers that they're not expecting.
Thank you. I'm going to put this next question to Robin and also to Kent. If you can put your hat back on when you did work in the payer space and specialty pharmacy space, how do you think the government intervening on the prices of these medicines and the change in risk shifting so that health insurers and biopharma companies will have more responsibility for the higher cost patients, how do you think that's going to affect formulary placement, utilization management, their ability to get rebates? If you want to comment on any or all of those, maybe we'll start off with Robin.
So if the payers are assuming more risk, they're limited to what they can do in terms of raising premiums. When you pinch a payer or squeeze a balloon, things pop out in other areas. So when you take a look, you have to consider some factors with this. There has to be, they're going to look for cost offsets and they're going to look for savings if history is any indication of what these payers will do. So some factors to consider: would they look or ask for more discounts or different things in the commercial books of business? Will there be more stringent formularies, especially in Med D now? And very likely there is going to be more utilization management, more stringent controls on the formulary drugs that are on. The greater utilization and management, they need to cut costs and find costs elsewhere. So there's potential implications of that happening. And they're probably going to focus more on the high cost specialty drugs and their negotiation for those high cost specialty drugs that are launching and currently already in the market. 340B negotiations are already contentious between manufacturers and the big payers, and this could continue that without fail. They're on offshore GPO negotiations that are occurring. What would happen with that? And lastly, we know that there's medical benefit discounts that are already in the system and being asked for. So our manufacturer is going to be pinched greater in these areas. When you take a look at the big, large, sophisticated biopharmaceutical companies, both parties are very skilled at the dance. They know how to work together. They'll figure a way to work this out. But when you take a look at the smaller, less diversified manufacturers, this could be really problematic and more difficult for them. And, would that hurt innovation down the road? You also have to weigh the payer impacts on potentially employers in other markets. So if you think of just Med D alone, are some of these smaller Med D players going to be able to absorb this risk? right? Are they going to be available? Which means choice and access issues. You also have to take a look at if a patient has less access to drugs on formulary, and the providers are going to potentially have more formulary or utilization management and control mechanisms, that's going to create barriers in the system and problems and costs in the system as well. And would commercial employer premiums rise? Now, some would argue if employer premiums in the commercial markets rise, that employers will hopefully want to see cost offsets for that. May fuel innovation and greater value-based healthcare in regional and national markets. Well, the large employers have the ability to do that, but the mid-tier employers, they won't have this kind of leverage. So when you really think about specialty and infusion providers that are out in the market that haven't been gobbled up by the big three to date, the payers are going to go after these folks for their in-network agreements as well, both retail, specialty pharmacy, and infusion. So history has shown when something is pinched or squeezed, those cost offsets and those cost savings need to come somewhere, and they won't all be derived on the back of the payers.
So I'm hearing a little more consolidation. And Ken, what are your views?
Yeah, I couldn't agree more. I mean, I'd say if we take the Part D benefit and just considering what the numbers are in 2025 and beyond, and it's shifting in 24 already, the payers are going to be responsible for about 60% of the cost in the catastrophic phase for medications. And in the oncology space, again, an area that we're competing in, if medications on average are costing $180,000 to $200,000 per annum, and there's only a $2,000 out-of-pocket cost for the patient now, then it stands to reason that that patient won't drop off of therapy the way they had been once they hit catastrophic. In that particular example, just to illustrate it, you would think the age of a population in the non-small cell lung cancer space would largely skew towards Medicare. And so the utilization of these drugs would probably at least be 50-50, if not 60-40 Medicare to commercial. What we're finding in the market today, it's actually flipped. It's about 65 to 70% commercial versus Medicare for the balance of that. Patients are dropping off of therapy when they're paying 5% of the cost of the medication. So this is great for patients, but if that lack of adherence to therapy occurs, and this is just the underbelly of the equation here, patient drops off the medication and doesn't cost the system or Medicare any of that additional cost, well, then now the patient isn't actually paying anything for that, stands to reason they're going to be on therapy longer. That means costs are going to go up. So just as the risk is moving to the manufacturer, but primarily to the payer, they're spending even more in the catastrophic on these medications. Now, according to Kaiser Family Foundation, only about 3.5% of patients are actually entering into catastrophic, at least as of about 2019. But currently, and this breaks out between, of course, today, Medicare is footing most of the bill. It's about $65 billion in annual spend in the catastrophic, even though it's a very small percentage of patients. Now, on the one hand, you'd say, well, then they probably won't do too much changes to the formulary because it's impacting only a small percentage of those patients, not when it has that large of a price tag associated with it. So one of the things that's going to be part of this challenging equation is that, well, premiums, at least in the commercial market, would go up to make up for that difference, and they're limited. They can't have the premiums go up according to the legislation. And you'd mentioned it before, when you consider in the last decade and a half or more that premiums have only gone up $2. I mean, this has really been an unbelievably successful program, but it's largely because the gross to net has grown so large that all those rebates go to buy down the premium. Well, that means they're going to have to get that from manufacturers. Those rebates are going to have to grow considerably in order for the premium buy down, which is limited for them, to stay. There's no money left for them to assume that risk. They have to pay out of pocket. So I think one of a couple of things are going to happen. Those that are entrenched in Medicare, such as Humana or my former employer, United, CVS, of course, they've got efficiencies of scale, and they'll be able to adapt and adjust, even though it will be a hit. And I think definitely, to Robin's point, manufacturers are not going to be negotiating just in Medicare, they're negotiating in commercial. And if a payer's hit in Medicare, well, they're going to take it from commercial as well. So there's going to have impacts on both sides of this. But if there's smaller players, even state-run, Blues Association, whatever they may be, that are playing in Medicare, it's kind of an all-in or all-out business anyway. And there's very, very, very slim margins because it's all passed through. I think there's going to be much more consolidation within the Medicare space. You're not going to be able to play in this space, given that kind of risk shift. So I think that's going to be a business implication to it. But if there is more restriction in this space, there's also going to be a timing issue here, as well as one of the other components of the IRA that wasn't fully explained is that these rebates and cost down, this pricing that they're actually proposing is at the point of sale. Well, how does that actually get adjudicated at the point of sale? So this is similar to the rebate rule that the Trump administration tried to implement without any real explanation of what is the PBM role versus the pharmacy role and how does that get calculated. They've got time compared to what the Trump administration was trying to administer, which was about a 6-month implementation to figure that out. But that changes the entire construct of how rebate flow works from PBM into government. That still has quite a bit to work out. And obviously from a payer perspective, having that shift in risk and the catastrophic, that comment period is going to be an interesting one in terms of what their response to that would be. But it's absolutely going to be on the back of the manufacturers.
This is my last formal question. I'm going to put it to Ryan, and Jack is collecting questions from anyone who's viewing. So I'll give you a minute if you want to ask something to send Jack an email. So Ryan, companies like yours depend on engaging investors. You don't have appropriations to do your business model. So what are the kinds of questions you're getting from investors and things they hope to see clarity on to sustain their interest in a business like yours that's aiming to develop more efficient, lower cost medicines? Okay.
Same. I think it's a wait and see. What Kent and Robin just talked about were distortions on distortions on distortions, right? So, and what do investors not like? They don't like the inability to predict future cash flows. So it kind of causes everything to freeze. So let's see, let's wait, let's watch, let's understand how this is going to work out. And again, to what Kent and Robin said, it's going to take a while. It's going to take a while to figure out what changed here, what moved there. There's some good things, and Kent mentioned it, the 2,000 max out of pocket, huge. People are going to be on therapy who could not have been on therapy before. They're not going to drop off. It's great for the patient. That's a potential very good thing that happens on our side of the business. But everything else, there's just so much uncertainty there. We've kind of glossed over 340B a couple times, but here I think because this becomes the Medicare price, if I'm not mistaken, that best price gets set, jargon alert, goes into your Medicaid AMP, which then goes directly into 340B, which, as Robin mentioned, is already highly contentious. You've got manufacturer after manufacturer trying to or pulling out of 340B. So to answer your question in a very short way, it just makes them scared. And they don't like to be scared. They like certainty.
Thank you. Okay, lightning round for my last question. If you could change one thing about the IRA, what would it be? I'm going to start with Kent, maybe in a sentence or two.
Well, I think the one thing that I would change right out of the gate is that the risk that they have between manufacturer and payer is softened. This is an extreme risk. The system, even with a couple of years to prepare for it, is not going to be able to adjust to that. I think that the POS version of this is a holdover from the Trump administration, which is unnecessary. I don't think the flow of rebate needs to be changed if they're implementing this act in totality. I would change those two if I were able to.
Ryan?
I would give it more time. I know that, 2026, I think, is the first implementation, but if you're choosing drugs here relatively shortly, I mentioned the Humira biosimilar market before, I would let that play out personally, see what happens, see what the market can do on a $20 billion drug. And then, then break the system, because as Kent said, this is breaking the system.
Thank you. And Robin?
Really, they missed an opportunity to provide a comprehensive value network for how you really take a look at drug innovation and affordability and improved benefits in health. This would have been an ideal opportunity to bring providers, manufacturers, and payers together to share data, to really take a look at how are we improving the potential health outcomes, the net cost health benefit of healthcare. This could have impacted government and commercial markets, and there clearly could have been a more scientific approach to doing this.
Thank you all so much. Really enjoyed a private sector focused conversation. And thanks to AEI for hosting us.
Thank you.